The time is now 12:30, so I'll just get started with some housekeeping items. My name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. We are the sister program to Maryland BHIP, the Maryland Behavioral Health Integration in Pediatric Primary Care. And we'll get a little more into both of those services and what they offer and why we're collaborating today. But first, I'm just going to go over the CME CEU process. So following today's webinar, you will receive a copy of the slides as well as next steps for filling out the survey for your CME or CEU certificate. Please allow 1 to 2 business days for us to process your credit and send you out your certificate. In those emails, you'll also have links to our resources so you can follow up with us and have our contact information. And I'll get into our MAC services. So the Maryland Addiction Consultation Service is a state-funded program through the Behavioral Health Administration. So all of our services are completely free. And we're here to provide support to prescribers and their practices, pharmacists, and healthcare teams in addressing the needs of their patients with substance use disorders and chronic pain management. And those services include a phone consultation line. So that's a warm line from 9 to 5, Monday through Friday. And you can call us with patient-specific questions as long as it is de-identified, or you can call us with broader practice questions from policies to protocols you'd like to implement. We also offer education and training opportunities related to substance use disorders and chronic pain management. Similar to today, they usually are 1 to 2 hour webinars, usually during the lunch break, as well as longer trainings, including waiver trainings that can be 4 hours or 8 hours to get you a waiver to prescribe buprenorphine. We also offer assistance with addiction and behavioral health resources and referrals, technical assistance to practices implementing or expanding office-based treatment, and Max Tele-Echo clinics, which are collaborative medical education through didactic presentations and case-based learning. So how that works is someone from the learning community brings a case from their own practice and presents it to a panel of consultants as well as other members of the learning community. They receive feedback on how to best treat that patient, and then there's a didactic presentation by one of our consultants. So it's a great way to get to know others as well as earn CMEs. And now I will turn it over to our program director, Kelly Coble, who is also the program director of BHIP, so she can give you an overview of BHIP services.
Thanks, Bridget, and thanks, Dr. Fishman. We're really glad to have you with us today, as a lot of folks that are joining us for the webinar, hey, Mark, probably know this is Children's Mental Health Matters Week, and Max and BHIP are both proud partners of the Children's Mental Health Matters campaign, and we're excited on this final week, at least weekday, day of the campaign to celebrate with a webinar, bringing attention and awareness as the campaign does to issues related to children's mental health. So we're excited to welcome Dr. Fishman, and I will just quickly give a nod to some of the services that BHIP offers in case you're not familiar. Really quite similar to what Max offers. BHIP offers consultation, training, education, and technical assistance for providers across the state. So BHIP serves pediatric primary care providers, and we're pretty liberal with that definition. So if any pediatrician, family physician, nurse practitioner, PA, anyone that's providing primary care to kids or adolescents from infancy to transitional age youth can use our services. And you can see them here on the screen. That's kind of our bread and butter service of phone consultation, which, as Bridget mentioned with Max, is open 9 to 5, Monday through Friday. You have access to behavioral health experts that range from child psychiatrists to psychologists or social workers, and they can answer any questions you might have about managing the behavioral health needs of your patients. And then we also provide some additional supports, and you heard a number of those mentioned, but assistance with finding resources and referrals in your community. Social work co-location, we do provide some regionally specific master's level social work students that can be placed in primary care offices. So if you're interested in that service, please reach out. We are fortunate to be expanding that in some specific areas, particularly Western and Southern Maryland. So if you're a primary care provider and you're interested, you could drop me a chat or send me an email. And then we also offer Project Echo, some limited telemental health services, telecounseling, and telepsychology assessment support and care coordination. And we also provide Echo clinics. similar to what you heard described for Mac. So we're excited to have you hear more about our services and join us today. We're supported through funding from the Behavioral Health Administration and also through HRSA, which supports some of our direct patient care services. There's some resources you'll find added through the chat. And if you have any technical questions about what Bridget mentioned, please let us know that. We'll respond to those, and questions about the content from Dr. Fishman we'll try to get to as we move along or at the end. And I'm going to get ready to turn it over to Dr. Fishman with a brief intro, but you'll get to know him as we move through the afternoon. Dr. Mark Fishman is an addiction psychiatrist. He's the medical director of Maryland Treatment Centers and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. He leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient and outpatient programs. In that role, he has been involved in development and implementation of innovative programming in addiction and co-occurring disorder treatment. His clinical specialties include treatment of drug-involved and dual diagnosis youth, opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research work has focused on medication treatment for substance use disorders, as well as models of care and treatment outcomes in youth, in particular opioid addiction. He has been a president of the Maryland Society of Addiction Medicine and is currently a member of its board. And last but not least, we're really lucky to have Dr. Fishman as a consultant on our MAX program, and I'm glad to welcome him today. So I'll turn it over, Mark, to you.
Thank you. Well, afternoon, everyone. Thanks for joining on this kind of dreary, rainy day, but let's see if we can make this topic lively. We're here to talk about co-occurring disorders, that is the combination of psychiatric mental health problems and substance use disorders in youth. And by youth, I mean adults and young adults, thinking about a developmental phase rather than a strict chronological timetable. And here's what we'll try to get to today. It's a big topic. We could spend all day, all week on it, but for the next hour or so, I'll be talking in this whirlwind overview kind of peek at the topic. So I'll start with issues of vulnerability and risk and show you some prevalence of co-occurrence, talk a bit assessment and diagnosis, talk more and spend most of our time on treatment, both some general approaches to addressing and managing co-occurring disorders in the population, and then drilling down to particular substances, or should I say substance, and I'll focus on cannabis because it's the most common substance, or one of the most common substances after nicotine and alcohol, that our youths get into. Oh wait, I forgot, cannabis isn't a drug, right? But anyway, we can talk about it, and I know what's on people's minds, and I know that lots of the kids that we see and that you see are certainly using cannabis, and so it's of central concern. If people want to talk about other particular substances, whether those are stimulants, opioids, or others, by all means, we can have those conversations in the discussion and Q&A at the end. And then I want to talk about some particular symptoms and disorders, depression, ADHD, anxiety, and the like. And then we'll have a couple of case illustrations. And when we get to the discussion, if you guys have some cases, by all means, let's bring those up and we can address those. So, summary, co-occurring psychiatric symptoms and disorders are common in youth with SUD. And although we may not be able to figure out the chicken and egg question, which came first, what causes what, they frequently go together. They are the rule rather than the exception, and they are reciprocally and mutually exacerbating. So SUD makes other psychiatric disorders worse. Psychiatric disorders makes SUD worse. And the prognosis of either disorder is worsened by the presence of the other, which is, as I said, very common. But optimistically, outcomes are improved in both disorders when they are both considered and treated. Differentiating the symptoms versus the disorders and making these diagnoses in a precise way is difficult, and there is an important explicit trade-off in case formulation in sensitivity versus specificity, which we'll talk about when we talk about assessment and when we talk about treatment. That is, if you see a person with mental health symptoms in the context of substance use, how quick do you want to be to make a diagnosis of an independent psychiatric disorder? And how quick do you want to be to institute specific symptoms rather than, for example, wait for reductions or absence of substances? An important kind of practice question that we'll talk some more about. But the good news is that aggressive treatment for both sets of disorders in an integrated current way is largely safe, definitely effective, and helps both sets of disorders. So as much as we might have some imprecision in our diagnostic precision, an assertive approach is supported by the research and by consensus in practice as being safe and effective. And then we'll get into some special circumstances, particular circumstances in certain conditions and substances. So let's start with the scope of the problem. Here's use of substances. Actually, this is percentage of prevalence of dependence, but use rates have the same shape across the life for tobacco, cannabis, and alcohol. The shape for other substances is the same, although the amplitude would be. And the important take-homes are that substance use and substance use disorder, to oversimplify things, nevertheless, a salient take-home message, substance use disorder is a developmental problem of pediatric origin, right? So you see that onset of substance use disorders happens in the middle of the second decade of life, and prevalence peaks at the end of the second decade of life, beginning of the third decade of life. So this is definitely a problem that is developmental and of pediatric origin. There aren't plenty of people on the right hand of the slide into the rest of the lifespan that have substance use disorders. But when did they start, right? They get started when they are teens. And so we've got to be concerned with the ascending limb of the curve. That's a prevention message. And it's also an early intervention message. As with all chronic relapsing disorders, the earlier you intervene, the more likely you are to be able to lasting difference in terms of improving trajectories and improving outcomes before the disorder becomes more advanced, more evolved, more crystallized, more malignant, right? And then the second take-home point here on the bottom is these arrows that indicate onset of common psychiatric disorders. As you're aware of, psychiatric disorders have onset across the lifespan before the age of 15, and 3/4 of psychiatric disorders have onset before the age of 24. So co-occurrence, as I said, is the rule rather than the exception. And even if there were not enriched overlap or causal relationship or mutually exacerbation relationship, just by chronological co-occurrence, we would expect to see lots of it. But as it turns out, the populations are also enriched. Among populations of people with SUD, youth with SUD, there is more psychiatric disorder, and among populations of youth with psychiatric disorders, there is more occurrence of SUD. And here is one indication of that. This looks at initiation of alcohol and initiation of drugs, non-alcohol drugs, among adolescents in relationship to having had or not having had major depressive episode in the past year. So you can see that the risk of initiation of alcohol and the risk of initiation of drugs is tripled based on having depression. And I can't tell you from this data, chicken or egg, which came first, but the point is they go together. And having one increases the risk of the other. And so dual diagnosis shouldn't surprise us. And not only is that co-occurrence related to initiation of substances, but it is related to the prognosis of the course of substance use disorder. So this is data from a cohort of adolescents admitted to high-intensity, short-term acute residential treatment at baseline, looking at the severity of their substance use as measured by the percentage of substance-using days in the past 90 days. So when these kids come into substance use disorder treatment, they're using almost every day on average, not so surprising, because to meet criteria for getting residential treatment, you have to be high severity. And then over the course of follow-up, so they get discharged after 30 days or so, and then they're followed at 3, 6, 9, and 12 months in the community. And you can see the classic check mark, right, of pre-post treatment outcome. That is, at first follow-up in the community after release, they've had very substantial and clinically quite significant improvements in their status with dramatic reductions in substance use, not to zero, right? So not a curative treatment, but a very, very impactful and effective treatment. And then over time, there's attenuation of the treatment effect as there is out from continuing outpatient care, as there is reintroduction to substance using peers and communities, and relapse. So over time, the treatment effect attenuates, but at a year, even with attenuation, there is still a substantial improvement from baseline. Again, not curative, not zero, but much better than we started. So one take-home message here is that substance use treatment is effective, but then the data divides the cohort into two groups: those with higher Beck Depression Inventory, BDI scores, and those with lower. And those with substantial depressive symptoms do worse in terms of their substance use at all time points, right? They don't improve quite as much, and they relapse to a greater extent in terms of their 6, 9, and 12-month treatment outcomes. So both treatment groups improve, but the depressed kids don't improve as much. And so that reminds us that prognosis is altered by co-occurring status, and reminds us that identifying depression as a co-occurrence is a critical target for intervention, and we need to do something about it. So how do we do that? Well, obviously the first thing to do is assess it, diagnose it, try to create the target for intervention. This is Gary Larson's view. Here I am sitting with a substance using teenager, and my notes say just plain, right? Hopefully we can do better than that. And our assessments are based on the premise that there is high morbidity, high comorbidity, and that we want to have a high of suspicion. We will be seeing pre-morbid mental health symptoms, that is, prior to the onset of substance use. We will be seeing drug-induced psychological symptoms, but it will be difficult, as we'll talk about in a minute, to sort those out. And so we usually think about the drug exacerbated, and we often can't tell the chicken and egg question. The phrase historically that you've heard, right, is dual diagnosis, sometimes used colloquially for this more modern occurrence, but dual diagnosis sets us up for thinking about two diagnoses. And when was the last time that any of the kids you guys treat only had two diagnoses? So polydiagnosis might be more accurate. But the idea is that co-occurrence, as I keep saying, is the rule rather than the exception. So here's the cartoon that reminds us of the chicken problem. And sometimes you can figure it out. That is, youngsters who've had affective instability and problems in emotional regulation, or symptoms of ADHD or what have you in earlier childhood prior to the age of exposure and onset of substance use. And that can be helpful. Or the other way around, kids who never had disturbance in their psychological life until they met substances, and we have cases of toxidromes or substance-induced psychiatric disorders that if only we got lucky enough to induce abstinence, they would resolve spontaneously. But the problem is we mostly can't tell, right? And so you talk to parents about age of onset, and what do you hear? You hear, well, when did he start having trouble with depression, anxiety, inattention, what have you? Oh, I don't know, early adolescence, 11, 12, 13, I don't know, something like that. Okay, when did he start using? I don't know, early adolescence, 11, 12, 13, 14, something like that, right? So mostly it's a mishmash, and we can't answer this question. And it may not be the right question. It might be, as I'm going to advocate, that we want to approach this concurrent treatment together in an integrated fashion, whichever. And I'll come back to that in a second, but there are a couple of approaches that can help us sort it out when we can sort it out. If you're looking for figuring out chronological primacy, you can use that. That's often difficult. So what are the other clues that we're going to make a diagnosis of an autonomous or an independent psychiatric disorder that is an additional specific target of treatment? These will all be the things that you're familiar with in doing your evaluations. Is there a family history of psychiatric? Were there symptoms? Here's the chronological primacy. Were there symptoms prior to substance use? Were there persistence of symptoms during episodes, if they existed, of periods of substance abstinence or periods of reduced substance use? Like, well, I spent the summer with my grandmother in another state and I wasn't using that summer. Or I was locked up temporarily. Or I was on a sports team and the coach was watching me like a hawk and I didn't use for a few months. It is, were those symptoms persistent? And that can be a clue. If there are signals from cumulative previous evaluations or cumulus previous treatment responses, either to psychotherapy or to medications, that can be helpful. And then, of course, severity of symptoms, the more urgent you are in consideration of imminent harm and other severity urgency factors, the more likely you are to jump on an independent course of treatment, say, in the most extreme case, suicidality, obviously, but other things as well that make you say, gosh, this is somebody who, even if I'm not sure of, I've got to jump on. Now, I want to talk about another feature of co-occurrence to illustrate for you a very common feature of the generation, the mutual exacerbation and generation of concurrent symptoms. This is a bit of a complicated slide. Let me walk you through it. We all know about the mechanism in the etiology of substance use disorder of primary reward reinforcement. That is, people use substances because they cause euphoria, because they make them high, because they like them. Think about a rat maze for the cheese reward. Think about the oversimplified cartoon dopamine reward system in the motivational of the brain, ventral tegmental area, nucleus accumbens, et cetera, et cetera. You guys all know that story. But one of the things that perhaps is underestimated and underappreciated is, as opposed to positive reinforcement, which I just talked about, negative reinforcement. Remember, negative reinforcement is the increase in a behavior due to relief of something bad, as opposed to reinforcement, which is increase in something good causes the behavior or reinforces the behavior. Here, decrease in something bad increases the behavior or the occurrence or the frequency of the behavior. And for those of you who have experience in taking care of high severity substance patients, this won't be a shock to you. Lots of patients, especially adult patients who are more road miles on them and talk about, will say, well, I've been using so long now, I don't even get high anymore, right? It's not fun for me anymore. It's just about trying to get back to trying to feel semi-normal, trying to feel less bad, right? And so we talk as a reward deficit problem, ongoing negative reinforcement. And so here's a cartoon of how that perhaps works. Look on the upper left-hand side and think about moving into state A above zero as the intoxication phase. And this is more in the time in which positive reinforcement is more salient. Somebody uses a substance, they get a euphoric, good, high feeling, and then after a time that goes away and comes back towards normal. And then maybe there's some aftermath, the morning after, the hangover, the regret, ooh, I did something kind of stupid. By contrast, life is not as colorful and rosy through the everyday lens as it was during the intoxication experience. But then that B experience attenuates and you get back to normal, right? And that's the kind of usual cycle of intermittent substance use reinforced by the effect. But over time, the upper right-hand side, with tolerance, the thing you guys know about, where the same amount of the substance produces less effect, or it takes more of the substance to produce a similar effect, the peak of the intoxication experience is less, and the decay of the intoxication experience is quicker. But the morning after phenomenon becomes more profound and stronger. That's both because contrast with the intoxication becomes more magnified, because the consequences and the surplus of accumulated stress builds over time, and because there are withdrawal phenomena as you get physiologically dependent. And then on the bottom graph is the dynamic over time view, so that this is in a progressive way, and over time, the peak reward diminishes and the peak morning after negative effect increases and increases to the point that normal resets in a downward slope and becomes the new normal in the negative state. And increasingly, people who are using habitually more regularly with loss of control are having harder and harder times, not just getting back to euphoria, but getting back to normal. And the best they can do is keep pushing the button of intoxication to back to that new normal. And that doesn't even work. But in contrast to all the enforcement, school, work, love, peers, relationship, sports, math homework, sex, food, music, whatever, that button has the highest effect, but even that button doesn't work so well, but people keep pushing it. Now, that's one model of addiction, but the reason I want to illustrate that is because it is congruent with a phenomenon of loss of hedonic capacity, right? That is, the mechanism for pleasure and reward and satisfaction and interest in interaction with the environment decays. Like your pleasure center is increasingly damaged and maybe even to the point of broken with increasing tone of anhedonia. Now, what psychiatric does that remind you of? Sounds a lot like major depression and other psychiatric conditions. And so it's no wonder that advancing severe substance use looks a lot like depression and maybe is even in many people indistinguishable. And we won't go into it today, but there's plenty of neuroscience research that shows us there are overlapping neurobiological mechanisms. Now, having said that, we still come back to the problem of precision in making the diagnosis. Treat or don't treat. Allow for spontaneous resolution if only we could get to abstinence, or not. Now, by the way, if only we could get to abstinence is no trivial matter, right? But put that on pause. In advance, prognostically and prospectively, trying to decide what to do. And I want to say that there is no standard. So don't feel bad if this is vexing. It's vexing for all of us, even for people like myself who do this, and this is our subspecialty, right? There is no blood test, there is no CAT scan, there is no EEG that can give us the precision that we want. So one of the things that I would advise you to do is to be explicit about the stance you take here. And I'm going to make the case that it's not right or wrong, it's just an approach. And you can do this in a cartoon kind of way to emphasize specificity or to emphasize specificity. And you're going to get it right sometimes, and you're going to get it wrong sometimes. And that's okay as long as you're explicit. You can wait for the possibility of spontaneous resolution of the substance problem to see whether the other psychiatric symptoms melt away or resolve gradually over time. Melt away is too dramatic. And that would give you better specificity, right? And better diagnostic precision. And you would then be exposing fewer people to the possibility of unnecessary treatments and unnecessary side effects if you wait to see whether to start an antidepressant, an antipsychotic, whatever. But the trade-off is you would lose the opportunity for earlier treatment for some people who might have needed it and for whom it would be effective, right? On the other hand, you could move ahead assertively or aggressively with a presumptive diagnosis with more sensitivity and less specificity, less diagnostic precision, and your risk would be that you would perhaps expose people over aggressively to treatments and potential side effects that they turn out not to have needed, but you'd have a better opportunity for earlier treatment and catch people who needed that treatment earlier and who otherwise might have dropped out, not waited around for decreases in substance use or abstinence, right? So there's no right answer here, and I've made plenty of mistakes in both directions. So the key is be explicit about your bias, if you will, and continue to collect assessment data and treatment response data and be prepared to change your mind. But be explicit. Now, I will tell you, me personally, both because I'm a bit of a treatment cowboy, but also because I see patients in a tertiary care setting with very high severity, and most of them have had plenty of trials already of no treatment. I tend to be more in camp 2. So I paint a broader brushstroke and err on the side of sensitivity versus specificity, thinking that I'm going to get to people who need treatment for co-occurring disorders earlier and catch more folks. But I do that explicitly understanding that I will overtreat some people, and sometimes that will create opportunity for side effects. But again, the idea is be explicit, be prepared to change your hypothesis. And here's just a joke about the kinds of treatment we do. Here's the drowning guy, and Lassie says, "I'll get help." And there he is on the couch. Maybe not so effective, the psychoanalytic treatment of substance use disorders. But anyway, let's talk about treatment. Uh, so we want to do that treatment concurrently. Integrated is, if not integrated, at least with coordination between separate providers, but not as in the old-fashioned approach in a serial way. That is, psychiatric treatment provider says, well, I can't treat you for your psychiatric disorder until you get sober, come back later when you're sober. And substance use provider says, I can't treat you for your substance use disorder until you're not mentally ill. Go get treatment for mental illness and then come back, right? We want to coordinate those things. And the data suggests, and I'll show you some of that data, that it's much more effective when done in an integrated or at least coordinated way. We can use psychiatric medications. The standard tool chest of psychiatric medications, as it turns out, we are very fortunate, mostly does not have a bunch of drug-drug interactions that present safety problems with the typical street of misuse. A couple of exceptions to that, but for them, and we can talk about those if you want to get into the nitty-gritty details, but for the most part, we can safely proceed with our standard repertoire of medications. They will be modestly, somewhat less effective while people are still using, but they will mostly not present big problems. We want to have a longitudinal view, emphasizing engagement over the long term. And that's true of standard psychiatric treatment and standard substance use disorder treatment, and just as for their treatment in an integrated fashion and co-occurring way. Families are, and we can get lots of leverage with all youth treatment, as you guys well know, by involving families, and I think we underdo that and should do it more. We don't have curative treatments. We don't have them in substance, certainly don't have them in co-occurring disorders. So to expect instantaneous improvement is to set yourself up for failure. This is a 3 steps forward and 2 steps back kind of treatment. Sometimes it's a 1 step forward and 2 steps back kind of treatment. Remitting relapsing course with incremental progress, that's okay. And won't be to you guys who are used to working with young people. Behavior change often, perhaps most often, does not come with the epiphany of insight, right? It is not only incremental, but it comes in behavioral change for internal motivation often, and external leverage and external motivation as a way of getting to behavior change in young people is effective and anticipated as a more common, at least early on, mechanism of change. I'm going to talk about medications, but let's not forget counseling and psychotherapy, which is better. Yes. So the same thing in standard psychiatric mental health treatment, the combination of medications and treatments are synergistic with each other. The same thing applies here. And now I want to show you an example of some co-occurring outcomes from the research literature. So I'm going to show you 2 or 3 slides about one particular study, and the concepts here generalize. So this is work from Paula Riggs at the University of Colorado. She's one of the great pioneers of co-occurring disorder treatment in young people. And this was a study on the treatment of major depression in adolescents with substance use disorder. And these were folks that were actively using. They were mostly cannabis and alcohol using for moderate severity. They're not mostly cocaine, methamphetamine, and heroin using youth. But they were using pretty heavily alcohol and cannabis. And the question was, the format was a placebo-controlled treatment with fluoxetine, and the background treatment in both the fluoxetine group and the placebo group was CBT, cognitive behavioral therapy, for substance use disorder, and also had some components for depression, as many times our CBT for SUD does. And the questions were the ones you'd expect. Is fluoxetine in this using population with depression, is it safe? Is it effective? That placebo. And then does it not only improve depression outcomes, but does it improve substance use outcomes? All compelling questions, right? So here's the end of study summary of the effect of fluoxetine on depression. 60 and fluoxetine beats placebo. You'd expect that, but that's good news. The other good news is it was safe. So there weren't a whole bunch of adverse side effects, worsening of substance use outcomes, and the like. So that's good news, safe and effective. But you'll also notice, even though fluoxetine is more effective than placebo, there's a 52% remission rate in placebo, right? Well, that's, when you slow down and think about it, not surprising. First of all, we know that adolescent depression trials have high rates, placebo response rates, but also remember the background treatment here was 16 weeks of active CBT, and CBT treats depression. So some people were getting better with the psychotherapy. Some people were getting better with medicine, and some people were getting better with both. Here's looking at that over time, and you also won't be surprised to see that it's a delayed treatment effect, right? Because fluoxetine, like all of our antidepressants, the SSRIs, the SNRIs, the tricyclics, all of the antidepressants, take time to work, right? And so we are seeing that the main effects in the distinction between the treatment with fluoxetine and placebo don't really emerge till week 13, 16, right? So this is 3 months before we see a sustained effect. Now, that's a little longer than you might expect to see it in a non-co-occurring population. So that reminds us that although the medicines work in actively using youth, they may not work as well, but they still work. Now, what about the question of decreases in substance use? So it turns out that the fluoxetine group did not, perhaps contrary to expectations, did not have better substance use outcomes. What's up with that? Well, a different way of skinning this cat was dividing the outcomes not by fluoxetine versus placebo, but by depression responder versus depression non-responder. And so here, looking at substance use outcomes, days of use in the past 30 days, those whose depression got better in the blue bars are the ones whose substance use got better, and vice versa. And those whose substance use, those whose depression did not get better, the non-responders in the red bars, are the same ones whose substance use did not get better. Whether the depression got better from the antidepressant medication fluoxetine or psychotherapy or both, the take-home message is that they tend to get better together. And to expect one of these sets of disorders to respond without the other is generally not the case. Again, supporting an integrated or coordinated treatment approach in which we are focusing on a substance use treatment, here it was the psychosocial counseling for substance use, and a depression treatment, the fluoxetine plus the depression CBT. And when they work together, they work. When they don't work together, they're probably not working. Dr. Riggs has done similar work with ADHD with stimulants and gotten a similar response, maybe not as robust, but very similar. And others have done with other disorders. But this is, I think, the prototypical generalizable pattern that articulates the basis and the evidence for this integrated approach. So I just want one example in depth. Now I want to shift from the general approach to some more specific topics. So I'm going to talk about cannabis, and then I'm going to talk about some particular disorders. This is adult data. Well, this is across the lifespan, so it includes both young people and older people. But I show it as an example of the correlation between cannabis use and a wide variety of psychiatric disorders, to make the point that prevalence rates, sorts of psychiatric problems, are considerably worse in those with problem cannabis use compared to the generation. This data doesn't tell us chicken or egg. This data doesn't tell us which causes which, but it does make the point that, contrary to popular opinion, cannabis is actually a big deal, and that people are more likely to be psychiatrically ill and to have worse treatment outcomes. I'm not showing you the treatment outcomes here, but we know that from other data. More psychiatrically ill, worse treatment outcomes if they are cannabis users. That doesn't mean that who smokes cannabis becomes psychiatrically ill. That doesn't mean that everybody who initiates cannabis and every teenager who experiments a little bit develops a cannabis use disorder. It's the minority, but it is a substantial minority, and it has significant impact. So now I'm going to show you some specific disorders and interweave with that some evidence or some detail from cannabis use disorder literature to illustrate the impact of cannabis. So probably the most common complaint, set of symptoms, diagnosis that we see among our co-occurring adolescent patients is depression, right? See it all the time. And we see confusion with our nomenclature, don't we? You see this all the time, co-occurring or not, substances or not, that there's a lot of confusion in the language about what people mean among the lay public when we say depression, right? So it's confusing. We use this term major depression, major depressive disorder. And a lot of people think that we automatically translate that to melancholia, right? The classic kind of early 19th century depiction of melancholic depression as sadness. So little d depression in English, right, means sad mood. And patients say all the time, I'm not depressed. What are you talking about? But we know that all sorts of symptoms of affective instability and problems with mood regulation are characteristic of depression. And in adolescence, it's probably more often irritability and anger than it is sadness. That's fine. And mood swings, mood lability, and overreactivity are a common feature of major depression in our adolescents. You guys know that all too well. And just because people say mood swings, of course, it could be bipolar disorder, but there's a tenfold greater prevalence of unipolar major depression than bipolar disorder in the population, at least. And so it's much more likely that the mood swings of the adolescent and the overreactivity and the lability is depressive disorder, not bipolar disorder. Not that there isn't bipolar, but so depression is common. It's easy for families and kids to miss it. And it's easy for them to misinterpret the impact of cannabis. But antidepressants plus CBT are very effective. I showed you the Paula Riggs study that looked at fluoxetine. Our experience and consent tells us that any of the common antidepressants are roughly equivalent as they are in the general population. And we go through the same trial and error kind of way of picking the antidepressant, serial different trials, giving enough time for it to be effective. And it's okay if they are actively using, because we're waiting for that longer term effect. I showed you that time course. We're not surprised that it takes time. And it's got to go along with active substance use disorder treatment. We're not expecting solo treatment with an antidepressant to magically melt away the substance use, as I showed you in that data. Won't happen. Now, here's some cannabis impact. The patients will often say, "Doc, you don't understand. Cannabis is my medicine. I have a cannabis card. My bud tender says that the purple haze is better than your Prozac, Zoloft, Effexor." But here's some data from a big group of longitudinal studies pooling cases to about an N of 7,000 from Australia, looking at the frequency of cannabis use associated with increases in depression scores over time, from no use to increasing frequencies of use to more than weekly, and looking at that data stratified by age. And you can see that younger people are more vulnerable to this impact, both with higher amplitude depressive scores and increased slope of the relationship. Now, I don't want to exaggerate. These are not enormous changes in depressive scores. The scale is small and blown up. I don't mean to say one puff and you become suicidal. Not at all. But the take-home point is that the relationship between dose of cannabis and depressive scores goes north, not south, as the patients might have you believe. Now, what's that about? How can they both be true? That the patient says that it's the only thing that helps, and the data says au contraire. Well, because patients, when they report their intoxication response, well, they do feel relief. That's real. During peak blood level intoxication, people get relief. Remember the thing I was showing you about negative reinforcement and reward deficit with severity and chronicity of use disorder. It's the only tool they have. They're pushing that button to try to feel as good as they can, which translates into less bad, but it's what they got. Any intoxicant makes you temporarily less tuned in to suffering, makes you numb temporarily to distress. Cannabis, alcohol, heroin, that's a common pharmacological response that many of us who may not have substance use disorders, but have known the pharmacological benefits of a glass of wine after a stressful day, right? That's just a common pharmacological response. But it isn't a sustainable strategy with escalation and tolerance over time. So what the patients are reporting is their nostalgic recall of peak intoxication experience, but they're still saying, I feel bad. And they're missing this longitudinal view. So they are compatible, but this is what the data tells us. And here's another interesting set of data, that subset of adolescents and young adults from a big Ohio Medicaid claims data set. These are folks that had a diagnosis of major depression. The prevalence of cannabis use disorder in this particular cohort was 10%. And comparing those with the cannabis problems to those without the cannabis problems, cannabis use disorder was associated with a bunch of really interesting outcomes. Like, how about mortality and death by overdose? Think about that for a second. We don't usually think about cannabis use as being associated with mortality. Now, I'm not saying this is, nobody ever died of a cannabis overdose. These are probably a variety of other causes of mortality downstream, like association of cannabis use with other substance use disorders and other overdoses, or with risk of victimization and exposure to or traumatic injuries or other things. But the cannabis has impact. also death by homicide, and non-fatal self-harm attempts. So it's a particularly virulent and toxic impact in this co-occurring target population. Anxiety is another very common symptom, but I want to remind everybody that it's a symptom first and foremost before it's or a disease, right? So patients complain all the time, no, I don't have depression, I have anxiety, when we full well know that anxiety as a mood is one of the aberrant dysregulated moods among many with our patients with major depression, just as they may have sad mood or irritable mood or angry mood or worried mood. They may have anxious mood, and it's part and parcel of their affective disorder. And many of these patients will say, I've tried everything, doc, and nothing works except, you guessed it, vitamin Z, although that's a misspelling, Xanax. And again, why is our experience that benzos are generally bad for mood disorders longitudinally, and the patients report that they are the only thing that helps? How can those both be true at the same time? And again, it's this issue of immediate relief versus lasting relief, escalation of dose and tolerance over time, and an unsustainable strategy that causes worsening rebound with withdrawal, etc. So SSRIs plus CBT, standard treatment, are most effective, but that's frustrating to patients who want relief. Cannabis is what helps now. Xanax is what helps now. And by the way, I don't want your stinking antidepressants because I have anxiety. Give me the anti-anxiety juice, please. ADHD, right? Another very co-occurring set of symptoms, also a disorder, but again, I want to distinguish the symptoms from the syndrome. And the inattention differential is very broad, right? Lots of people have symptoms of poor concentration, inattention, distractibility with depression and anxiety. Substances can certainly cause problems and concentration problems. And life stressors certainly cause inattention and problems with concentration. Now, lots of patients, especially substance using patients who are used to wanting an immediate effect from their pharmacology, their street pharmacology, but they'd like to come to you to get easier access. Lots of patients will ask for stimulants. And one of the things to remember about stimulants is that the improvement of attention with prescription stimulants is in no way a verification of a diagnosis of ADHD, right? It's just an expression of a standard pharmacological effect of stimulants, right? Stimulants improve concentration and attention and reduce distractibility in whoever takes them, right? So think of caffeine, even if you've never, some of you may not have snorted out. Anybody who's ever had a cup of coffee knows that caffeine is a drug in its pharmacological impact, and having a pro-attentional response to a shot of espresso does not mean you hypo-Starbucks anemia disorder. It just means that everybody has the same response to stimulants, including caffeine on the mild end of the spectrum, and very reinforcing. So we just got to be careful about jumping to what the patients may want in terms of the reinforcement of their liking the very reinforced of the protect with, well, is this really the right diagnosis? So in general, I think treating ADHD with co-occurring substance use is a good idea. I tend to lead with non-stimulants. And I'll tell you why in a second. And there are a bunch of non-stimulant medications that are quite good, but I also use stimulants, and I continue stimulants if people are doing well. uh, but certainly use long preparations rather than short-acting preparations. We want to minimize the immediate onset, offset reinforcement. Vyvanse, dexamphetamine, Vyvanse as a prodrug has the benefit of being slow onset. Oros methylphenidate or Concerta benefit of its harsh and misuse because it's a goo inside. But any of the long-acting preparations are okay, but full monitoring. Dose escalation, for using supplies up early. Drug screening needs to be a standard part of stimulant treatment. I would say in all young people, but certainly in young people where there is risk of or suspicion of or knowledge of co-occurring substance use. And sometimes an abstinence contingency or an improvement in SUD outcome contingency is a useful strategy. That is, fine, we can treat you with stimulants. I'm glad to see that they're helping, but that goes with needing to pay to and improve your substance use outcome. So happy to give you stimulants as long as you're reducing or stopping your cannabis, alcohol, heroin, whatever it is. And you can decide what the bright line is and how those correlate, but that can be very useful. Here's the reason why I tend to start with non-stimulants, and by those I mean the SNRIs or bupropion, or although we don't use tricyclics in younger adolescents, with young adults, nortriptyline is a good anti-ADHD agent. But the reason is because of the characteristic side effect profile of stimulants. It's not that I'm not concerned with misuse and diversion. Sure, there are some people who escalate their use. There are some people who crush it and sniff it or inject it or whatever. There are certainly people who like the intoxicating effects of overuse of stimulants. But more salient and problematic in a more common way in my practice is the worsening of affective disorders. That is, they can cause anxiety and irritability. They can make depression. Occasionally, you can cause psychosis, but that's pretty rare. Mostly, it's this side file with co-occurring depression, which is very common. And the patients will sometimes minimize that because they're so reinforced by the pro-attentional effects. Whereas if you lead with SNRIs or bupropion or other things that might give you dual coverage for both depression and ADHD, be able to address both. Now, if you can't, as I say, are a reasonable approach as long as you do careful monitoring. Here's just a reminder about side effects, right? Tapeworms as a weight loss treatment, not our best in the history of medicine. Anyway, another prescription stimulants is that they have the reputation on the street by many young people, high school, college students, etc., of being smart drugs. So whether or not they have official diagnoses of ADHD or whether or not they're in medical treatment for ADHD, there's the notion that non-medical street use of stimulants, whether you buy them on the street or you borrow them from your cousin or your roommate has a prescription for ADHD, whatever it is, that they can be study aids and that they can help you do better in school and that they are performance cognitive enhancers. Well, it turns out that received wisdom is actually not true. So this is interesting data about college students who use prescription stimulants without a prescription. And you shouldn't be surprised to see that the people who are using one set of substances, in this case prescription stimulants, without a prescription, might also be using other substances non-medically, like cannabis, cocaine, opiates, and nicotine, right? At the rates of other dangerous substance behaviors like binge drinking, riding with a drunk driver, driving after drinking, and driving after binge drinking have substantially increased rates of occurrence in people who are using prescription stimulants non-medically. And in another study, those same folks had lower grades, not higher grades, and had higher rates of skipping classes, going out at night and partying, and lower rates of doing the old-fashioned things that people might do to improve their grades, like spending time doing their homework or studying. So important to debunk the notion that, yeah, any single use of prescription stimulants, as I said, has a pharmacological approach, but it's not a sustainable strategy in non-medical, non-supervised use. If a person has ADHD and they're using appropriately as prescribed under monitoring, yes, then of course you get functional outcome improvements, including academic performance, but not in casual non-medical. And so that reminds us, let's not forget the psychosocial treatments for problems with attention and concentration, whether that goes along with a full diagnosis of ADHD or whether it's attention caused by other things in the broader differential diagnosis. All of these things that those of you who treat ADHD know all too well, that there's this whole host of other things that we, besides the medications, that are super helpful in young people as they are maturing and need to learn additional skills for time management or using notes and calendars and rehearsing skills, etc. Another not so common, but definitely impactful set of disorders are the psychotic disorders. And they are less common, but we see them obviously in the schizophrenia family, in psychotic mood disorders, depression with bipolar with psychotic features, and substance-induced psychosis. And one of the things that is hard for the rest of us to understand is how it is that if substances either cause psychosis or make it worse for some people, how come they don't stop? Psychosis seems like it's such a distressing and miserable experience. You would think that if you know that, for example, smoking cocaine or injecting ketamine or smoking cannabis makes it worse, that would make you want to quit. Well, enough, not as much as you might think, right? The reinforcements of the intoxication effect far outstrip, for most people, the punishing effect that they experience by worsened psychosis. So that alone doesn't do it. And poor self-recognition of the in general in psychotic disorders, as you know, is the rule, right? Most people with advanced psychosis have trouble telling the difference. Poor adherence to medications is common, and even worse with co-occurrence, because substance use causes cognitive problems, causes chaos in life circumstances, et cetera, et cetera. And although antipsychotics are good, they're not good enough. And so very important to do all the usual, for those of you who treat psychotic disorders, of a garden variety, plain vanilla cases of schizophrenia and other psychotic disorders, we redouble our efforts in co-occurring disorders where there is concurrent substance use. And I can't emphasize enough how important it is to work on engagement and treatment adherence. And I will tell you that I am a huge fan of long-acting injectable antipsychotics, even in first episode, even in substance-induced, even if I wonder if it's going to go away, because non-adherence is the rule rather than the exception, and there is no reason to wait for treatment non-adherence and failure, because, as I say, it's the rule. So getting people onto long-acting injectables, if they'll take it, and not everybody will, early if possible, is well worth doing. And for those of you who don't know this literature, I just want to remind you, again, coming back to the theme of the impact of cannabis, that all minority experience, and most people who smoke cannabis don't get psychosis, it does considerably worsen the risk. And this is just one study, a big prospective cohort out of Germany, but it's been replicated again and again. And here we see that you got a double the incidence of new onset psychosis with use of cannabis and double the risk of persistence of psychosis with cannabis continuation. And some more recent studies that have looked at dose response with either frequency or THC concentration with high potency vaping and wax dabs and the like. Some people have come up with odds ratios as high as 6, so 6-fold increases in the risk of psychosis. And unfortunately, although many people with substance-induced psychosis from cannabis resolve spontaneously if they cut down or stop, unfortunately, many don't, and many persist with what turns into a psychotic syndrome indistinguishable from schizophrenia. And whether that has to do with having a pre-existing vulnerability or not, we're not sophisticated enough to know, but these studies are generally controlled for family history of schizophrenia. So we know at least that to some extent, there is an independent effect of the toxicity of cannabis. Although not a syndrome, not a disorder, not a diagnosis, insomnia as a common symptom of many of the disorders we've been talking about is not only very common, and sometimes a feature of withdrawal. For example, cannabis withdrawal. Those of you who don't know about cannabis withdrawal, nobody ever died of it. You don't have to go to the hospital from it. It doesn't cause death, but it is certainly a profound phenomenon. Most young people don't recognize it. And insomnia is one of its primary features. And since we are fortunate enough to have a set of tools, both pharmacological and sleep hygiene wise, to be able to address poor sleep, a lot of credibility points and a lot of impact by being aggressive about trying to address insomnia. So it's one of my go-to early targets. Right? Antidepressants take a long time to work. Mood stabilizers take a long time to work. Even antipsychotics are slow. But we can generally get movement with their sleep pretty darn quick. Diphenhydramine over the counter, melatonin, low-dose trazodone, etc. Choose what you want. Non-habit forming, non-dangerous, simple to use. Low-dose hypnotics are easy. And they're big relapse triggers. If you can't sleep unless you smoke a big fat blunt every night, it's hard to quit. So there's an additional benefit in addressing that. So just to wrap up, psychiatric comorbidity is common, and it increases the severity of the impairment and worsens the outcome compared to either set of disorders alone. The unmet need is enormous. The presentation and the diagnosis can be tricky. And it requires thoughtfulness and careful monitoring over time and systematic testing of hypotheses with some tolerance of imprecision. That's okay. But treatment is effective when done as part of a concurrent integrated approach. And it's not only the prescribers, but it is perhaps as importantly or more importantly, the primary care providers and the the therapists, the counselors, the program leaders, the peers, other people who have more touch with the patients other than the medical staff and the subspecialists, because they will have the primary relationships. And so people got to stretch a bit outside their wheelhouse and do some of this work as advocates for engagement and getting people to enter treatment and participate in treatment. And so in that way, I say you are the main ingredient, because in the end, our relationships are, if not our best tool, certainly one of our best tools, and often, our best tool. Here's Gary Larson again. I'm a big fan. Bobo remained free the rest of his life, although he did find it necessary to seek counseling. These, as I've said before, are longer-term problems. These are longitudinal perspectives we need to have rather than surgical approaches. And I've got some cases, but rather than do that, let me take some questions and ask you guys what's and hear some of your cases. And if we run out of steam, we can come back to my cases.
Thank you so much, Dr. Fishman. This is always a webinar that everyone looks forward to when we do this Max BHIP crossover. We do have a couple questions that came up throughout the training, and they do have a similar theme to them. So this first question came up while you were talking about SUD and depression. And the question is, do you have any recommendations or resources for excessive denial of parents for teenagers using vapes or Xanax or pain pills? And they said we use PHQ-9 mod craft.
So the PHQ is a nice screening and longitudinal monitoring tool for depression. The craft as a screener for substance use is pretty good. It's a qualitative screener, those of you who don't know it, as opposed to the cage, the more kind of well-known adult thing that asks about, have you ever tried to cut down? Do you feel guilty? Adolescents don't feel guilty about anything, about their substance use. So the craft is a developmentally informed qualitative screener for substance use that includes things like, do adults fuss at you about your substance use? Have you ever driven in a car with somebody using substances? Have you ever been in trouble for in association with your substance use? And that's kind of that external orientation of adolescents. They're not trying to cut down or have internal motivation. So those are good tools. But and sometimes showing these data points to parents can be helpful. But I think it's about building relationship, more importantly, and trying to educate the parents. And boy, is that tough, right? We hear all the time, oh, it's no big deal. We did it when we were kids. We lived through it. It's only marijuana after all. They should learn to drink at home, where we'll teach them moderation and how to drink responsibly. And again, it turns out that it's in total contradiction with the data. Early initiation is associated with higher rates of progression to disorder, persistence of disorder into adulthood, and worse outcome and prognosis. Period. Now, that's a hard, but you got to just keep saying that. One of the things I say to parents, I get that if there were only two doors, door number one and door number two, that is, drink on the street, drive drunk, and die in a car crash, door number one, versus drink at home under my supervision and I take your keys away. Well, if those are the doors, yeah, door number one. But what about door number three? Let me help you not initiate drinking. And what about if I set a stick that delay of intoxication behaviors is advocating, harder to do, but it's another door. Again, if there's only two doors, alcohol versus heroin, cannabis versus heroin, if those are the only two choices, sure, heroin's worser, but why are those the only two choices? So I think getting families to understand that they do have the potential for having impact. They have more juice than they know. They are not hypocrites if they advocate for delay of initiation, reduction in use, or full abstinence just because they did it when they were young. We expect better of the next generation. We expect the next generation to learn mistakes. And by the way, the potency of cannabis on the street these days in terms of THC content, it's not your grandfather's slim little reefer from the jazz age. It's a much more potent drug with tenfold increases in potency. And the big blunts that young people on the deep end are using several times a day, is a much higher dose of ingestion. And the vaping and the availability of edibles, it's a very different kind of toxicity compared to the 0.5% stem seeds that your parents were smoking. I will say another myth busting thing that I talk to both parents and is the line, everybody's doing it. You hear this all the time. Well, a lot of people are doing it, but it sure ain't everybody. 50% of 12th graders have tried cannabis. but 50% haven't. So that's a lot of people who are using it, but it sure ain't everybody. Maybe everybody you know is using, but that's a cohort bias based on the peers you're hanging out with. There's plenty of nerds in your class who aren't smoking. Not only that for cannabis, but this will surprise you maybe. What do you think the proportion of 12th graders that have never in their lifetime, not just tried cannabis, but haven't ever tried cannabis, alcohol, or nicotine? Who's got a guess?
One guess is 10% in the chat.
Yeah, that's a very common kind of thing. It's pretty rare, right? Well, it is the minority, but the answer is 30%. Almost a third of 12th graders have never tried any of those substances. And fully a half of 12th graders have not used any of those substances in the past month. Now, lots have. Don't get me wrong. If 30% haven't tried, 70% have. And 6% of 12th graders use cannabis every day, and 1% of 8th graders. So it is a lot of people who are using, but it isn't everybody. And the rates of non-use are increasing. So we're doing something right. I'm not saying we can take credit for it, but things are going in part in the right direction. I don't know if that's a result of the culture or the result of the messaging or a result of the generational trauma of the opioid crisis and people seeing people die around them and temporarily backing off. I don't know, but I'll take it. But on the other hand, there certainly is a cohort on the extreme side where we see a bimodal distribution that some subpopulation of young people are using increasingly lots and with high, and that speaks to the numbers of 6 to 8% of 12th graders using daily. And we will expect that to increase as the society moves more in the direction of being pre-contemplative, still decreased perceptions of harm, increasing access through, quote, medicalization or legalization. Expect trouble. And when the big girls of Wall Street get a hold of mass marketing, just as they have done with alcohol and tobacco, we will see, I believe, upticks, and we'll have to contend with that. Anyway, what else do people want to ask? What else you got?
So this next question is sort of related to that last one, and it is do you have any thoughts about parents and families who are reluctant to seek help with cannabis, AUD, and other disorders?
Yeah, well, you can't make them. All you can do is be available and work on engagement and therapeutic alliance. And one of the ways that we try to do this, as with all our motivational enhancement approaches, is to try to meet them where they are. So they come to you for something, and that something might be concern about depression. It might be concern about wanting contraception or reproductive health services, or it might be with problems with academic performance and do they have ADHD? Anyway, whatever the thing is. And then it turns out that, oh, by the way, there's some drinking and some cannabis use, but they don't connect the dots. Well, one of the things to do is to draw them in with being able to help them with the thing they want help with, but helping them over in a motivational way connect those dots that they haven't connected, and showing them that although you can make some progress, whether it's treating ADHD or treating depression or trying to help with relationship problems, that the ongoing progression of the substance problem is interfering with the goals that they seek help with, and that you're giving the message, this has got to be on the table. We can agree to disagree. I use that phrase all the time. We can agree to disagree, but thanks for having the conversation with me. Thanks for exploring it in an honest, transparent way. Thanks for telling me your point of view. This is no big deal. It's not a problem. I'm not in trouble. I don't smoke anywhere near as much as my neighbors, whatever. But let's keep, and what I hope to show you over time is that I can help you even more if you'll pay attention to these other things. And I will hope to show you longitudinally that these problems, at least for a subset of young people, will tend to progress. So, for example, the conversation might be, all right, you say it's no big deal. You say it doesn't impair your life. All right. Not sure we agree. We can agree to disagree. That's fine. But tell me, what hypothetically would be the red line past which it might be a problem? And you see what that does? It gets us maybe closer to the same page, that even though they don't think they've crossed the line, there is such a thing as too much. Well, I only smoke on the weekends. I guess if I smoked, that'd be too much. I only smoke after school. I guess if I smoked at lunchtime or before school, maybe that would be too much. Well, all right. And then next time you meet, hold up the mirror of the pageant of their own life back in your notes, and you say, well, last time you told me you were only smoking on the weekends, but now you're telling me you smoked last. What's up with that? Oh, I've changed my mind. Wednesdays are okay too. Or, well, you said that before school would be a problem. Yeah, well, it actually helps me before math class. All right, but now we can show them with a series of longitudinal crossing of lines that they said they would never cross, that maybe it's more of an impact than they thought. So that can be a way of trying to gradually draw them in. But it is a marathon, not a sprint. And don't expect the results to drop from their eyes in a moment of epiphany and have it be clear sailing into the sunset, singing Kumbaya together all in one fell swoop. It's not going to go like that. And it's the same with the parents. What is it, parents, that you can do? There's nothing I can do. I have no influence. Everybody's doing it. Well, no, wait. What about, you have more juice than you know. What about if you were to tailor the goodies and the treats in your house to particular outcomes? Well, I can't pay people. I don't have the money for it. No, I'm not talking about that. I'm talking about what it is you already do in the house. Is it a fancy meal? Is it special outings? Is it gas money? Is it access to the car? Is it treats? I don't know, whatever you do in your house. But now let's pick some goals around treatment outcomes. Is it showing up at treatment? Is it having negative drug tests? Is it taking your depression medicine? Is it meeting with the therapist? Is it, whatever it is? How about in an informal way, creating a paradigm of positive reinforcement, or as we call it in the substance use disorder treatment literature, management, in an informal way, and give rewards and goodies for particular outcomes. And parents get a little confused by that, but they can get on board if you encourage them. And even if they don't do what we say right away, it's still important to be clear in our messaging. In the same way that we say, wear a seatbelt, wear a bicycle helmet, wear a condom, whatever other health messages we give, which we do every day without batting an eye, we're not naive enough to think that just because we say it, they're going to always do it. But because of, as healthcare providers, and I say the same thing to parents, because of your status as parental caregivers, because of your status and moral persuasion and therapeutic alliance and relationship and love and caring and all of those things, we are the voices that they carry around in their heads, and they won't always follow our instructions, but we are there with the credibility of our expertise. And so we need to be clear and not wishy-washy and not confused about our supposed hypocrisy. The right amount of substance intoxicant for adolescents is 0. I'm not saying that people aren't going to experiment, just as they experiment with all sorts of shenanigans. But that's the message. And young people should delay initiation of intoxicants till at least 18, preferably to 21. That's my story, and I'm sticking to it.
Thank you so much, Dr. Fishman. Do you have time for one more question?
Oh, yeah. I'll stay till the cows come home. You know that, but you guys are busy, so you don't have to stay.
Okay, I'm just going to say some closing remarks since it is 2 p.m. and then I'll read that last question. So thank you everyone for joining. If you do have additional questions for Dr. Fishman, please reach out to Max or BHIP, and we're happy to connect you to him or another one of our consultants.
And
I
you
did
see
put
my
our-
email address as well. Feel free.
And I did put our contact information in the chat, so feel free to save that. That will also be included in the follow-up emails. Just look out for emails with the slides as well as a link to the evaluation survey. But I will get into this last question, and I think you may have addressed it a little bit with that last answer. But the question is, do you have any thoughts on how the state or clinicians as a whole can address the public perception issue regarding cannabis, given what research and clinician experience has taught us?
Well, unfortunately, I'm a little pessimistic about our ability to change the overwhelming momentum of the society. You know, intoxication is imbued in our culture, for young people especially, as signifying the good life and luxury and well-being. The example of Hollywood and pop stars and the icons of youth pop culture always got a drink in their hand or a big blunt in their hand like Snoop. And so it's hard to fight with that. And it's only becoming more prevalent. And therefore, when the big boys and girls of Wall Street get a hold of it, it's going to be even worse. You remember Joe Camel for cigarettes? Well, you know, Ziggy Marley and Willie Nelson are all geared up for their brands of cannabis, and it's going to be like that. So our ability to counter that message, it's the water that young people swim in, is tough, but we still need to try. I unfortunately think that the medicalization, so-called medicalization phenomena is a problem. We saw what happened in the opioid crisis a decade ago, as we said that more opioids as first-line analgesia, despite the lack of evidence for efficacy and despite the clear evidence for significant danger profile. We saw where that got us. Expect that again. And we see where the message, oh, don't worry, you guys, we're not going to allow access for people under 21. Don't you worry. Yeah, how's that going for you for alcohol? So I think there's trouble ahead. I think that increasingly that's what the society has scripted. So we're just going to have to live with it and counter message it. And the way to counter message it is not by allowing them to cast us, I don't know, the forces of cannabis advocacy, whoever they are, but not to allow ourselves to be cast as puritanistic prohibitionists. None of us are saying that this is the devil's scourge and a moral failing, and that cannabis should be eliminated from the face of the earth as the devil's weed. No, I don't care what you do at home as a mature adult in the private of your house any more than I care if you drink a beer at a football game. It's none of my business. I'm concerned about vulnerable people who get into trouble, and youth are very vulnerable, and disproportionately high rates of escalation, loss of control, and use disorder. If the general population among people who tried cannabis gets into trouble 10 to 20% of the time, for youth it's 40 to 50% of the time. That's a big differential. Again, it's not every youth, right? In fact, most youth don't get into trouble, but a large number do. And so we have to message it not as a issue, not that we are prudes, but that we are concerned with health. The same way that we give a health message about nicotine, the same way we give a health message about underage drinking, the same way we give a health message about indiscriminate sex and contraception and the prevention of this. All the stuff that we do every day. This is not judgmental. This is about health. And we just have to keep saying it again and again, both as a general public health message, perhaps more impactfully for the individuals we encounter one at a time, especially those where we see early initiation and progression to disorder. We have to screen, we have to treat either in the general setting or by referral to a specialty setting. And we can't turn a blind eye by saying that there's nothing we can do. There's a ton we can do, and I expect all of you will go do it.
Awesome. Thank you so much. This was all great information. We've received overwhelmingly great feedback in the chat, so everyone really took a lot out of today's talk. Look out for that recording. It will be on the Max website in 1 week. I'm not seeing any other questions in the chat. Once again, if you do have questions, please reach out to Max or BHIP. But Dr. Fishman, thank you so much for your time. If there are prescribers online, we are going to walk through the application for a 30-patient limit to prescribe buprenorphine. So if you are interested in doing that, please put your name followed by HHS into the chat. And if we get some responses, I will go through that. But Dr. Fishman, thank you for the time today. Feel free to log off, and I'll keep you posted if any other questions come our way.
And are we going to do the bupe bit now?
Yeah, I'll be walking through that. So you can stay on if you want to. No,
yeah, I'll stay on because I think there's a lot of interest in this small group of high severity opioid using young people. And so if there are questions about that, I'll hang around. Yeah.
Awesome. Thank you so much. So once again, if you are interested in walking through this application, please put your name followed by HHS into the chat. And you do have to be a prescriber to complete this application. So that's physicians, physician's assistants, or advanced practicing registered nurses. And just to give a little bit more of an overview while I wait for others to confirm that they will be walking through this with us. Basically, a little over a year ago, SAMHSA decided that they were going to waive the required 8-hour training for physicians and 24-hour training for physician's assistants and nurse practitioners, so that those providers can apply to prescribe buprenorphine to up to a 30-patient limit, just to remove that barrier of the training so they can get more people waivered to prescribe. So I am going to share the screen for walking through that application. First, I'm going to put the application link into the chat. So open that up and I'll walk you through it. If for any reason you cannot walk through this today, maybe you don't have enough time to, please reach out to Max and we're happy to walk you through this over the phone, one-on-one, individually, to answer any specific questions. But Dr. Fishman's online with us today to answer those questions as well. Just so you all are aware, I will not be able to see the chat during this portion, but there are other Max team members that will be able to help you out if you do have questions that come up, so just bear with us. Are you all seeing presenter mode or just the slides?
Presenter mode with both the current and next slide.
Okay, let me see if I could switch that. How about now? Just the slides?
You still have next slide.
Okay, we'll just leave that up. If anyone needs to zoom in or anything, I can include these slides on the follow-up email as well. But this is what the page will look like when you do go to apply for your waiver. So please make sure that you have your DEA number and your state medical license number. It says training certificate information, but you actually do not need to include that since you are applying for only the 30-patient limit. That's for those who do go through the whole waiver training and are looking to expand from that 30-patient limit after 1 year of practicing with a waiver. So you're going to answer this first question if it applies to you. Then on this next page, you are going to enter your licensing state, your state medical license number, and your DEA number. Please make sure that you enter this information correctly because this is the part of the form that will check your waiver eligibility to see if you are eligible to prescribe buprenorphine. And now the system will indicate the number of patients you are eligible to submit a notification for. So as you can see, it will say eligible for waiver level 30. So that just means that you will only be able to prescribe within a 30-patient limit. And your medical state license, your state medical license and your DEA number will be pre-populated. Just give those a look over again to make sure that information is accurate. Next, you're going to enter your name, license number, all of that will be pre-populated again. Just double check that you are entering it correctly. Then you're going to enter your address. Please make sure that this is accurate and it is your practicing address and not your personal address, because the DEA remains the right to audit you and show up just to check in on how you are practicing. This doesn't happen. I think this happens very rarely, but if they do, it's a pretty casual visit, but you don't want them showing up to your home. So just make sure that your practice address is accurate. And if any of this contact information changes between when you apply for your waiver and when you are practicing, just make sure you contact SAMHSA to update it, because this is the information that they will use to contact you. Next, you're going to fill out the purpose of notification. So this is just acknowledging that you are only approved to use Schedule 3, 4, and 5 medications. And certification of qualifying criteria. Check any of these that apply to you. Once again, ignore the information about the certificates, because you will not be completing the training. If you are interested in completing the full training and eventually expanding that practice limit, please reach out to Max, because we're always holding waiver trainings to help those who are interested in that. Next, you're going to walk through the certification of capacity, certification of maximum patient load, and consent to release contact information. This consent to release contact information is optional. That just means that you would be included on a contact list where patients will be able to find that you are accepting new patients. And then you are finally going to type your name in the box as your signature. Type in your DEA number matching the one that you entered initially. Once again, just double check this to ensure that it is all accurate. And if you fill this all out correctly, this is what the page will look like, and this will confirm that you have officially applied for your waiver. I am going to ask you to pause at this step and screenshot this screen on your computer and send it to Max. That just helps us know that you did walk through this process with us today, and we will send you a reward to the address that you registered with. So just look out for that. And we are also happy to answer any questions you have with prescribing buprenorphine in the future once you do get started. SAMHSA will email you a confirmation right away that you did submit this application, and then within 45 days, they will confirm that you are eligible to prescribe buprenorphine within that 30 patient limit. We've gotten a lot of feedback that it's usually sooner. So if that 45th day passes, please contact SAMHSA and just check in to see the state of your application and make sure that you are on track. But those are the end of the slides. Dr. Fishman, I am going to ask you just to fill in any gaps I may have left, or if there's any information that I did not accurately describe, but you as a clinician probably have a little more information than I do.
Well, I will say that those of you who are in pre-contemplation or contemplation or even preparation about thinking about this process of incorporating buprenorphine treatment into your practices, I would want to encourage you. It's a relatively easy medication to use and a forgiving medication. Some people are reluctant to do it because people know that I prescribe buprenorphine. Suddenly my waiting room will be filled with young people who are seeking treatment for opioid use disorder, and that's not my subspecialty, and that's not necessarily what I want, but I think that has not been most people's experience. The reason perhaps to do this, I mean, certainly if you want to be a specialist, a subspecialist, that's perfectly appropriate, but most people's experience is that there are people already in your practice, whether you know about them or you don't know about them, that have trouble with opioid use disorder. And this just gives you one more tool in your tool chest to be able to manage those folks in an integrated way. And it doesn't have to be a big part of your practice. It can just be one patient. It can just be two patients, but it's worth giving it a try it's a very rewarding experience. Doesn't work for everybody. Not everybody gets better, no more than everybody gets better with any condition or any medication, but worth a try, very satisfying. And if you're looking for guidance about how to do it, how to get started, pro tips about ways of pursuing treatment with an individual patient, please reach out to Max, reach out to me individually. Happy to be a coach, because we need more people to do this kind of work and to encourage patients and families. And these young people with opioid use disorder, they are usually not as treatment presenting as we'd like. We know they're out there. We know it's a big problem. We know that they are at great danger, including high mortality risk of fatal overdose, but they are reluctant to present for treatment. So if you have a relationship, if they do present, use the motivational moment, grab them and go, sending them elsewhere. That gap is sometimes more than they can bridge. So you to give it a try. You don't like it, you don't have to keep doing it, but try.
Awesome. Thank you so much, Dr. Fishman. I'm not seeing any other questions in the chat, but if, once again, I put our Max contact information, we're happy to connect you to Dr. Fishman. And thank you all for staying on a little bit late. And thank you, especially Dr. Fishman. I know this is over our allotted time, but your webinars are always so well received, so we really appreciate it today.
Great. Thanks, everyone, for your attention. Hope that's helpful.
Awesome. All right. Thank you so much.
Have a good weekend. Bye.
You too. Bye.